Hey, Dr. Bakhtari. So how's it going today?
Good, good. Thanks for having me on. Big
Yes,
honor. Thank you.
yeah. So I know you're a busy man, but we really appreciate you taking the time to come down here and or really to speak to us. So
Sure, my pleasure.
for anybody that doesn't really know, could you please tell us about your medical journey and your credentials and all of that?
Sure, sure. More than happy to. So yeah, I went to medical school at Ohio State University, and then I
OH,
went to
baby.
yeah, go Ohio State.
Yeah.
And then I went to Northwestern University for my residency in internal medicine, then UCLA for my fellowship in pulmonary and critical care. Then I, joined a big group and became a partner in a pulmonary critical care group, and then subsequently got to teach as clinical faculty in several medical schools, and then worked my way into hospital administration, and then working for health insurance companies, and then eventually, starting our own company. So that's been an abbreviated version of the history of my medical track.
Yes, yeah, because your track has kind of gone all over the place. Like when I was looking up everything, from essentially starting out to going all the way to the CEO now of multiple
Mhm.
companies. So I definitely want to ask you about that. First, though, I do want to mention that my granddad's going to be so happy because he's a huge Ohio State fan. So we were pretty much raised. I mean, I think my first football game was an Ohio State game when I was like 2. So
Oh, you're
they were
kidding.
they were super excited. Um,
Right.
yeah. So um, first, I guess I wanted to ask you really about your transition. So you started out in your specialties were internal medicine and pulm crit, right?
Yeah, those three. Yeah, I got
So
board certified in all three of them
mhm.
initially. Yeah.
So do you still practice or is it just have you switched hands to the CEO?
Yeah, more CEO stuff. I mean, obviously, I still see occasional patients, and I also, uh, help mentor my clinical staff. So
Hmm.
that's really full-time work too, just mentoring and addressing their needs and questions and policies and procedures and quality improvement and other initiatives.
Exactly. So I'm guessing you still have to take the boards on all three of those still, even
Yeah,
after.
no, I keep my license active, obviously, because I do some clinical work, but no, I let them expire eventually because I just, stopped practicing pulmonary and critical care. But had them for, a decade or two, and then just let them lapse after got more into the administrative side.
Mm. Because that's what I was thinking. I was like, man, for you to be doing all this and still be triple board certified, I was like, I wonder if they still make him take all
I
three of
meant
the tests.
I missed the cutoff. If I had done it 1 year earlier, that would have been for life. That they changed that to every 10 years. Literally,
Hmm.
I think the year I took the boards. But the people 1 year before were grandfathered for life, so there was no retaking him back then.
Oh, yeah, yeah, the what some people don't realize when they look on the outside of medicine is that I mean, you have to essentially renew your board certification
Yes, yeah,
every, and
yeah.
so you have to go and relearn all the stuff that you had been learning.
Yeah, I remember doing that. Especially, I remember doing it for my pulmonary, recertifying 10 years later, and yeah, just it's interesting because when you recertify, it's the first time you also have like 10 years of clinical experience under your belt. So it makes studying for the boards a little bit of a different experience than when you were studying it the first time, because the first time you did it, you have no clinical experience essentially other than training. And but then second time you have 10 years, like if you do ER and then go recertify 10 years later. Well, you've been working in an ER, room for 10 years. Now you're retaking the board. So things kind of, I don't want to say make more sense, but things that, are relevant will hit you easier
Hmm.
after you have, some history and experience. So it is interesting retaking it.
You can only hope that things haven't changed, and then you go to take the board and you have
Yeah,
the old
yeah,
answer still on there.
yeah. You know what? It's interesting because when you're doing it every day, you keep up. You just kind of by almost, just go to enough conferences, and it's just you're pretty much cutting edge as you evolve, because as new
Hmm.
things come out, you know, it just can't help but stay on top of it. So that wasn't the problem. I think the problem really was going back to some of the, you know, maybe pathology, physiology of some of the stuff that was more basic science, which actually it wasn't that difficult, but I think uh, understanding, you know, how certain diseases work from a physiological level, you know, as it relates to clinical questions. So, but yeah, it's fun going back and doing it a second time. It really you have a level of experience and apprenticeship that helps you understand why they're asking certain questions and stuff.
Oh, I'm sure it's less nerve-wracking because I know, I mean, I'm just getting through with, or still having to, I still have one more big step test ahead of me, but those tests are nerve-wracking to begin with.
Yeah, it was
And
interesting because I was nervous too the second time, but and I said, "Oh, I'm going to start studying. I'm going to start studying," and you know, I was just so busy at work, I didn't really get around to really focusing, and you know, still passed, which is the funny thing because the first time, you, like you're saying, your nerves are racked and you're studying, and the second time you're just like so busy now that you know to try to fit in a lot of studying is hard. But go ahead.
oh, no, no. Like my mom, so she's an emergency physician, or she practices as an emergency physician, but she is like board certified in family medicine. So you can still practice
Wow.
in an ER. But so she's practiced emergency medicine for like 20 years.
Oh, wow.
And then they have to, but when she takes her board, she has to still take the family medicine one. So she's got to learn a
Oh,
whole new
wow.
like crash course, really. Um, that's what those conferences are for. You know, you
Right.
go to those
Yeah.
and
Yeah. As long as you go to those conferences in your specialty, you know, it's you're pretty up to date. And just from
mm-hmm,
going to, you know, different conferences at the hospital you're at or, you know, wherever you're working, it's really, it's not that difficult.
mm-hmm. I want to get to where your medical career changes to your business career, but first I want to take you back since we're on like these tests and residencies and stuff like that. So you decided to get your fellowship in Palm Crit. Was that a joint? Is that a joint thing, or were those two separate things at the same time? Did you
No,
have to do one
it
fellowship
was
and?
combined. I think what they did is, I think pulmonary is normally 2 years and critical care is normally 2 years. So most of the combined programs would then combine it in 3 years so you could get both, understanding that there's 1 year of overlap. So if you're doing critical care fellowship exclusively, you're going to have to do some pulmonary. And if you do a pulmonary fellowship, you're going to have to do some critical care. So I think that their logic was if you're doing both simultaneously, you should get credit and within 3 years be able to sit for both. And
Mhm,
so I think most programs and most, you know, Big Ten and Pac-10 schools and most programs are now combined or were combined. And I think the people who do it separately often are coming from different specialties, like maybe even ER or anesthesia. If they want to do it, then they'll just do a critical care fellowship.
mhm.
But the people coming out of internal medicine usually do pulmonary and critical care combined. The anesthesiologists who become critical care often just will do a 2 year critical care fellowship, or like ER might do a 2 year critical care fellowship. So if you do pulmonary critical care, that's when they shave off a year, I think.
Okay. That's definitely the smarter way, just because for one, you shave off the year, but especially in internal medicine and working in, I guess, like ICU or any of those critical care situations,
Mhm.
you're going to want both of those fellowships under your belt.
Yeah,
Um,
if it makes sense. If you're going to be working in an ICU, both of them really obviously help.
yeah. And so did you know that you wanted to do that going, I guess maybe even into medical school, but especially like when you started your internal medicine residency, did you know
No, I
that you
didn't.
wanted to?
No, I didn't. I mean, I think I didn't really realize until my third year after doing some critical care and pulmonary fellowships. And yeah, I think what attracted me was, you know, critical care has a lot of feedback data. You know, I always was interested in the art of medicine, but I thought the science of medicine was even more. You know, critical care is one of these few specialties that is data rich. You know, you're looking at the data of the Swan Ganz, the ventilator, you're looking at you're getting a lot of data. When you're doing primary care, you're not getting any data really. Yeah, maybe do a blood test or something, but a lot of it is the art of medicine, and using your stethoscope, and
Yeah.
you're doing a good physical exam, which of course is very important. But with critical care, you get to do that. Plus, you get tons of data. Like there's so much
Oh, yeah.
data coming back at you, right? And I love that concept of you can still practice the art of medicine, but the science of medicine. I'm very biased, but I don't think there's any specialty in medicine that's more rich in data and science than critical care, because you're looking at the dialysis machine, the ventilator, you're looking at the swan, you're looking at all these, catheters and other machines that you're using, that give you, and also the patient's being monitored continuously, getting continuous heart rate,
Mm-hmm.
continue, and continuous rhythms. And it's really unlike any other specialty. If anyone's like wanting to understand why critical care is so different, there is no other specialty that you get 24-hour monitoring of almost every aspect of that person's health.
Mm-hmm.
uh, and you're in charge of digesting all that data continuously. It's whatever rhythm the patient is in, you own that, right? I mean, like if they're in AFib or whatever, they're having a lot of arrhythmias. I mean, there's no getting away from that. It's not like the patient's sitting on an orthopedic floor and nobody knows what's going on. You're
Yeah.
constantly getting the feedback and data. So that's what makes it fun. If you're into like getting continuous feedback.
Oh, yeah. I mean, the amount of data is insane. When I was my first introduction, I guess, would be my like ICU rotation. I think okay. The first time it was, so COVID had hit and everything. I don't think I was allowed to do ICU immediately during my internal medicine, but then I was SICU and surgery and stuff like that. And I started to have to realize, and it was quite, like, inclusive or whatever. They made us do pretty much everything. And just to know all the stuff that was going on once you're in that ICU, it's pretty intense. Like you have to know a lot, and all the bags, everything, how much, like it's kind of a perfect science or whatever. You're mixing a lot of stuff and getting it, or like you were saying, literally, like it's very scientific. It's almost like a chemistry experiment or something. You're mixing a bunch of things trying to make sure it happens. But I mean, it's pretty amazing too. It keeps you on your or on your A game or whatever.
Mm-hmm.
Because there's always something to be looking at, something,
Mm-hmm.
some study. So that, and so how long did you practice in, like, I guess you worked in an ICU or?
Yeah. We did. I worked in, we saw patients in the ICU for, I would say, the majority of the day, but we had office hours, several half days a week on top of it. So it was,
Okay.
and also doing pulmonary consultations on the regular floor. So it was really ICU plus regular pulmonary plus office.
Okay. And then, whenever you started to kind of like transition from, like, when, I guess, did you decide that you wanted to go from medicine to being the CEO of, or did one of the CEOs start first, or because you're the CEO of, for one, the U.S. Drug Testing Center,
Yeah,
correct?
and
And then E7.
E7 Health, and then enational testing, which is our latest venture. No, the funny thing is, people think that, like you wake up one morning and say, okay, I'm changing. And it was nothing like that. It was a, 5-10 year evolution of just one door opening another. First you just got on a committee, then that opens another door where someone asks you to be on another committee, and that opens another door. And it was never one moment where it was simply, once I became a senior partner in the pulmonary critical care group, I started to want to get involved in more things. And so I just added those on and got on committees, and then became chairman of the department. And then someone asked me if I want to work part-time at, Anthem Blue Cross Blue Shield, as a medical director, and then other medical directorships opened up. And it was a very slow transition from clinical to administrative medicine to sort of, kind of starting our own companies. It was very slow, and it was like watching grass grow. You never realize it was happening. It just happened over pretty extended time. So, yeah, I think for a lot of doctors are like, oh, I'm going to quit medicine and go into this, or I'm going to stop clinical and go into that. In fact, on my podcast, Baktari MD, I did a whole episode on, quote unquote, leaving clinical medicine last year. And I talk about that, how it's not for people who want to wake up one day and change. That's not usually the best thing to do. The best thing I found is to, take a bite of the apple and see how that feels, and then see what door that opens up. So it wasn't very planned out. Like, this is okay. I'm doing this. It was more like, well, let me try that, see how I like it. And there were things I tried that I didn't like. So it wasn't like everything I tried, oh, that's great. So you have to balance, every position you take, whether it's working for a hospital or insurance company, whether it's working for private industry, there's pros and cons to all of those, and you have to see, what suits you. Because at the end of the day, I'm a clinician and I'm a patient advocate.
Mm-hmm.
And, that has to be part of everything I do. That's my core DNA. After trying to save lives in the ICU for a decade, you can't just say, oh, I'm just just going to be thinking about dollars and cents or whatever. It becomes who you are. All you care about is being a patient advocate, saving lives, or taking care of people, looking out for them. And the question is, as you expand, you want to take that with you, so you can impact people's lives, not just one at a time, which is what happens when you're doing clinical medicine. You're doing one patient at a time. You start thinking, well, are there things that we can deploy or that can make thousands of lives better? And I think that was the idea behind enational testing, E7 Health, and US Drug Test Centers. Were there technologies and processes that we could deploy to improve people's life, improve quality, reduce friction for the patients? And but I think having those other experiences kind of helped me understand what our mission should be. If that makes sense.
Yeah, I I actually really, and you can tell too by some of your podcasts and like the things that, and honestly, at your endeavors, that you're using your skill set. So you went and you did all, and you learned all this stuff about medicine. You've saved lives. That skill set allows you to transition to another phase of your life, whether that is, a CEO or whatever, but you're using the skills that you already have instead of just saying, oh, I'm going to do this and then force the world to switch to whatever now that I want to do this. And I think that allows you to have good quality work because that's what you're the expert in. And it's funny, you were saying you're a clinician by nature. It's very ICU in nature you were just saying that you're like the CEO of multiple companies. So you're not afraid to just accept responsibility and take the load on yourself, which is very ICU nature of, just, I'll be willing to accept anything.
Right. Well, when you're in the ICU, the buck stops with you. There's like there's nobody like behind you, right? So it is what it is. And
Yeah.
you're seeing 10, 15 patients a day in the ICU. You're like, okay, you own everything. But yeah, I think that's a good point. I think I've gotten the question like, do you regret the clinical part? You wish you had just done this from the beginning? And I think you hit the nail on the head. I don't think I would have had some of the soft skills and some of the insights without that clinical experience. So I don't think I would, be or have some of the skills that I have now without that clinical training, So I'm grateful for it. And it really does make an impact. And I think you hit the nail on the head that you bring that with you.
It certainly sets you apart. Did you ever experience, because I'm going into residency and I have all this, there's all this literature and everything now about like wellness and burnout and everything like that. Did you
Yeah.
ever experience a stage of that in your career that wanted you to like venture out into other things, or like, or was it just it happened? It was just so happenstance that everything kind of led to where it is.
Yeah, no, I don't think, I mean, I hear what you're saying because a lot of my colleagues went through that. I think I was fortunate in the sense that I did not. I mean, I really loved what I was doing, and it was a passion. I mean, I'm going to be brutally honest. I would say I used to joke that I had the world's best job in the world the first 40 hours of the week. You know, I mean, literally. So I have the greatest job on earth, you know, the first 40 hours of the week. And it's the second 40 hours that I was like, you know, not so thrilled about. So like nobody's thrilled about, you know, the nights, the weekends, the calls in the middle of the night. No, no one is. So I hear that, but no, I mean, for me, it was always a privilege and an honor to be in that position. I mean, it's there are not many people that get to do, you know, what we do, which is literally come home every day and say, you know, I saved some people's lives. I mean, who, you know, other than Superman, you know, who can say that? I mean, we are so fortunate and so lucky and so privileged to be given this opportunity. You can't take this for granted. I mean, oh my goodness, who gets to do this stuff? I mean,
I agree.
who gets to save people's lives? And it's just like another day at work, and then you come home and watch the ball game, whatever, and you're hanging out with your friends and family. But um, I remember when I was you know, doing my residency, and you would come home and you're just like, oh my gosh, what I just went through today. That you can't even share it with people because it was such an amazing experience. That how do you explain, you know, bringing people from the brink of you know, death and bringing them back, and you know, intubating and you know, whatever. And so it's a privilege. If you don't view it as a privilege and an honor, yeah, I could see how burnout could set in. I mean, it's
Hmm.
because the hours can be long, and you know, it's not fun. You know, I'm sure somebody in their 20s and 30s, you want to be, you know, you want to work hard, you want to put in a lot of hours, but you also want to, you know, hang out with your family.
Did you have any like tricks whenever you're on that second 40 hours, getting through it?
The second 40, yeah, that was a tough one. No, because you know, I really enjoyed it. I mean, it was, I think it made it easier because, you know, I love what I was doing. That's another thing. People think, you know, people who leave clinical medicine didn't like it, you know, but just to kind of switch gears on that, yeah, I loved it. And well, how could you leave if you loved it? You know, well, I don't know. You could love sushi, but you can't have it every night. I mean, that just, if one night you don't have sushi, does that mean you don't love it? Or if you don't have sushi for a week or a month or whatever, I mean,
You don't
you
have
can
it
love
every
some.
day, all the time.
No, you
Yeah.
can love it, but say, okay, you know, I want to see another movie. I mean, you know, I love The Godfather, but I like to see another movie now. So it's just, I think the whole idea that you can have multiple chapters in your life without like saying, oh, the last chapter, you know, something, you know, I was tired of, or whatever. You can love the first chapter, but then say, okay, I want to try a second chapter.
Hmm. Oh, I mean, and it's the difference of you have 10 to 15 patients that were critically ill and you were able to take care of them. But I think in your new venture, and you can't you couldn't ascend to where you're at right now, where you're able to navigate all these endeavors and go on these podcasts and like really help a broader range of people without your expertise to begin with. So you have to start with the 10 to 15. But I think
Mm-hmm.
you've kind of ascended to a point where you have enough outreach and everything that you can help more people. And in that case, why not also do that? You know, like you've already done your time, you spent your
Mm-hmm.
80 hours, like you should also um pass on the knowledge, like you were saying, with your tutoring and all that stuff too. So yeah, I think it's like a natural progression too, to share that knowledge, and I think it's better for everybody.
Yeah, thank you. And I've been fortunate enough to, you know, like some of the mentoring I did for residents and medical students, and when I was clinical faculty and whatever. So, some of those skill sets I use now to mentor the clinical people and the leadership people in my organization. So you're right, that the mentoring skills come with you, and of course we use it on our podcast and everything else. So we've been able to parlay that into helping my staff and doing our podcast and getting the information out. So yeah, you're right. Thank you for saying that.
Oh yeah, no, it's the honest truth. But whenever you were switching avenues to or maybe more the question is like weaning or fading out of clinical medicine and into your business endeavors, when did that start? Like, did that start with the U.S. drug testing
No,
centers,
we
or when?
opened up E7 Health back in 2009
Okay.
as a very small operation. And then US Drug Test Centers, I think it was a sister company that spawned off of E7 Health because we were doing drug testing in E7 Health. Then we launched, because we're really a technology company. We develop software and technology platforms for E7 Health. And then that platform allowed us to start US Drug Test Centers, and then more recently enational testing. So it really, I tell people we're not really a healthcare company. We're really a technology company masquerading as a healthcare company, because at the core, what makes us different is the amount of investments we've made into our own proprietary platforms and technology. Like if you go to E7 Health, you'll see we have 10,000 reviews from a third party, from patients, just in the last 3 years. That's a testimony to our technology and my great staff, because there's no clinic in the United States that has 10,000, or healthcare company that has 10,000 positive reviews and literally a 5.0 on Google. And from all the reviews we get on Google, and I think part of that is a testimony to our technology as well as my great staff. But when you marry a great staff with Amazon-esque technology,
Mm-hmm.
it's a powerful force.
Yeah. And so how did you find that staff to be like, because naturally, if you're coming in and I assume that it was started kind of by you, right? In conjunction, you were the one of the founders of E7, correct?
Yeah, I was a co-founder, and then eventually then took it over exclusively. Yes.
Okay. Yeah. And so that's what I was reading. But so how do you find, because it can't be you that develops every inch of the technology. Like you spent all this time learning about medicine. Now you understand the
Mm-hmm.
need in the medical field, but the transition to doing the computer tech and finding the right people to hire the right, how did
Mm-hmm.
you navigate that pathway? Did you have somebody that kind of helped you, or
Yeah,
are you really good
it's
at spotting
interesting.
talent?
Well, no, I think as a matter of fact, my second year of my podcast, which we're launching in the next few weeks, is called Crash CEO School. So it's what I've learned, whatever, how you enroll people into your vision, how do you spot leaders, how do you mentor leaders, how do you cultivate, how do you support. So I think and some of that was trial and error, especially in the early parts. But I think, yes, putting a team together, enrolling them into your vision,
Mm-hmm.
having them buy in, that is all part of it. And yeah, the technology, of course, I mean, I'm not developing the technology myself, but me and my senior staff are spearheading where we want the technology to be. We look at clinical problems and we say, okay, how can we solve that using technology, right? And we look
Mm-hmm.
at patient barriers, and how can we remove barriers to people getting what they want, right? I mean,
Exactly. Yeah.
if you're familiar with Amazon, what do? You go on Amazon, and if you need to order like a light bulb, what do you do on Amazon? You should be 3 clicks away from having
Mm-hmm.
the product delivered to your
In
doorstep.
24 hours.
Right. So we said, well, why can't we make healthcare like that? And so, I mean, once you view it like that, then it's pretty clear what you got to do, right? I mean,
Mm-hmm.
literally, at eNational Testing and E7 Health and US Drug Test Centers, you can light on your phone, but you're probably 4 or 5 clicks away from getting whatever you want. And
Okay, so that's what I wanted to ask you is that for like e-national testing. So I like looked into that one, and I assume because it was described almost Amazon like, where you should be able to order something. But does that mean that they will come to your house and take a like a testing for you at
no,
your
no,
house,
no, no,
or
no. We've contracted out with 5,000 locations across the country, often within a half a mile of where most people live if they live in a big city
okay,
or a medium-sized town. So literally, you just get your donor pass and you can walk in, get your test, and then your cholesterol test or your men's health panel, your prostate test, or whatever, and then literally, the results should be in your portal. Uh,
okay.
in a few days, if not sooner.
So give everybody a breakdown of like what exactly they can get from the like what kind of testing, and I guess they would
Yeah,
have to find one of the centers, like they would use the app
yeah.
and
You
then
put
find
in
a
you put
center.
in your zip code, and you put in your
That's
zip code, and all of a sudden it will populate the labs closest to you.
and that's on
Uh,
enationaltesting.com.
mm-hmm. In fact,
Do
yeah.
my
I
research.
mean, yeah. Good job.
I'm just
Uh,
I'm fine.
yeah. And so just so we have general wellness testing, which includes metabolic testing, cardiac risk panel monitoring, colon cancer screening, thyroid health panel. We have a men's health package. We have men's anti-aging, women's health packages. We have allergy testing, basic food testing, environmental allergies, employment testing, blood titers, quantiferon drug testing, STD testing.
Okay.
Uh,
So
so that
one-stop
kind of,
shop.
yeah, one-stop shop in all 50 states.
Okay, perfect. Yeah. So you can just go in, type your zip code in, and then um essentially you set them up. Do they need like anything to
No,
like a
we have physicians in all 50 states who then authorize the testing and send you the results.
oh,
So it's all automated.
perfect. Okay, well, that sounds easy. And I guess the drug testing center is the same, like the
Yeah,
where you
U.S.
just
drug test centers, but a lot of that is B2B. Businesses and companies use us to run their drug testing program within their company. So
okay.
if you're a trucking company or any other company that needs to do annual or random drug testing on your employees, we manage that through our platform, as well as we connect to 20,000 collection centers across the country that they can
Mm.
have the drug testing done for their employees, and even retail customers. But a lot of it is Department of Transportation drug testing and other regulated drug testing that needs to be done. Again, they use our platform to literally access 20,000 labs, but everything is ordered on our platform and the results come into our platform, and they get one bill from us, even if they use all 20,000 locations.
Okay. Yeah, so it kind of brings it all together. I at first I thought the US Drug Testing Center was that place that they like if you get a suspicious sample or whatever and they say, "Hey, we have
Mm-hmm.
to send it off to the lab." It'll take like 4 more days.
For
I
the
was like,
confirmation test. No, it's just
yeah.
standard drug. Yeah, it's just standard drug testing.
Oh,
So
it's just
every panel, hair panel, urine panels. Yeah, we have pretty much every
okay.
run of the mill drug testing that most companies and individuals need. We even test for steroids and a whole anything you can drug test. I think we have to test on our website.
I think that that's actually really beneficial as well because when I was looking up, like I had to get a drug test recently for like I also have been a scribe and blah blah blah. So the restarting work after, it's weird that you're about to be a doctor and then you still scribe, blah blah blah. But they the I go for this drug test, but they were like, you have to go find one closest to you. And actually like searching Google and everything, yes, it would take me to either one that was really far away that had a specific name that said drug testing in the name or
Yeah,
whatever. So if you're combining all of them and it's like a really easy, you can look at because
yeah,
I like typed
yeah.
in zip code and it was super far away, but there was actually one way closer.
Right.
And so I don't know what I guess I was typing in or whatever, but um, it's not as easy as it would seem as just a
Mhm.
simple. So having that like one place that probably is beneficial, like
Yeah,
a
a lot of
platform that
people.
monitors everything.
Yeah, that's why we literally have thousands of clients, and we have clients in almost every, oh, in every state and in almost every city.
So do you sign up for like E7 and then you have access to all
No,
of
no.
the
So
visit?
E7 Health is just the brick and mortar locations we have, in Nevada. So US Direct Test Centers is just sort of a virtual company that has these 20,000. E7 Health, because we give vaccines and do physicals and more preventive health. Those are so far in Nevada. We're hoping to expand regionally and then maybe nationally.
Okay, so e-national testing and E7
E7,
are
so
technically two separate things as well.
yes, right,
Like they would
because
be.
e-national testing is the whole country
Hmm.
accessing these thousands of labs. E7 Health is literally brick and mortar clinics that you go in and get your
Oh, okay, okay.
vaccines, if that makes sense. So it's not
Yeah.
a it's brick and mortar. E7 Health and eNational is uh, using these thousands of contracted laboratories that we have.
Okay. Yeah, I was just trying to get a grip on. So did you say that there was an app or is it just something that you
I mean,
would
you can order it on your phone. Yeah, so our all our websites are dynamic. So literally, you can, or
okay.
literally on for all three companies, you can get whatever you want on your cell phone.
That's pretty awesome. And so when did you have this idea like that you wanted to at least do like where you're working to, I guess, better distribute because that's what it seems like it is making healthcare a lot more accessible to like
Yeah.
the common person that does so they don't have to go see their family physician to get a script written so that they can go get a cholesterol taken
Well,
or whatever.
I think part of it is you just see the friction. Like if you right now try to call your doctor, you get a phone prompt that says press one, two, or three, and if this is for an appointment, press one. If this is for medical records, press two, and then you press two, and then it gives you three more prompts, and then after like a bunch of prompts, it says leave a message. We'll call you back in 24 hours, and their first appointment is in 8 weeks,
Mm-hmm.
and then we don't take your insurance anymore. It's just it's like a battle to get what you want. It's not anything close to Amazon.
It's very,
Uh,
yeah, no,
and then when you go in there, they give you a clipboard with 11 pages, and then you wait. And this, even with these seven help, we're brick and mortar. I mean, literally, you can book an appointment on your cell phone outside the clinic, walk into your appointment, and literally often walk out in 5-10 minutes. Literally, it's just there's no clipboard, no paperwork. Everything when you first book the appointment, we capture everything, and it's it's made a lot of people's lives easier. And that's what we're talking about: reducing friction.
okay.
Just making it an easier path. You're more, let's say you're thinking about getting something done. If it's going to be such a hassle to go, we know how patients think. It's just compliance and wanting to do things is it's hard. So we thought if we remove some of that and made it super easy, leveraging technology, would people welcome that? And that was our strategy.
I mean, I think that's a smart idea, especially within the times that we've been at where we've seen like COVID and all that. That severely reduced the amount of people that you could even just see in a normal day. So then
Right.
you've got all these other barriers set up that really prevent people that aren't like I have kind of grown up. I had mentioned or whatever that my mom's a physician, my grandmother's a
Mm.
nurse, and a lot of people are in healthcare. But if you don't have any family at all that's in healthcare,
Right.
it can
Right.
almost seem institutional, um, and that they're not out for your generalized health. You can
Yeah,
see.
you almost need an advocate. Like if you're a patient, someone in your family's got to be an advocate for you who knows the healthcare system often,
Yeah,
because it's hard to navigate it.
there's so many times where you even when you're just trying to get to the bottom of something, and then they have a family member in the room that is in healthcare, you can get through things just a little bit smoother.
Mhm.
Um, and even from the physician side of things, but or like just the healthcare worker. But if you're the family member that doesn't know what's going on, like because I have a whole nother side of my family that doesn't want wouldn't ever go to the doctor if they didn't, unless it was a emergency. And so yeah, it's just, it would be really difficult to explain just like simple things, or like, oh, you should really do this, take this pill, it's better for your cholesterol. Or,
Hmm.
even just saying daily vitamins, they're like, mm, are they really daily? You're like, okay,
Hmm.
like but all I'm just saying is that it can be really difficult to get people like on board if they're not within that kind of circle. And so I
Right.
think by also by you like reaching out and everything, and or being that connector,
Hmm.
that's beneficial,
Yeah.
especially in the times like with COVID and everything. We still don't
Right.
know uh what's going on. I think that they let the time lapse on the emergency status of it, but um who knows? I think people are a little bit more skeptical, like the people that were on the bridge of being skeptical or not skeptical,
Hmm.
they're even less skeptical or more skeptical now, which can be tough just coming from a healthcare workers uh, aspect of it.
Right. I agree.
And I guess kind of speaking, because I did mention in the intro and everything that you were listed as a vaccine expert. So I really just wanted to take, I know if you may not have a lot of time, but maybe we can just
Oh, I'm fine.
okay, yeah. No, I just didn't know what even that like what qualifies, or how do you get that qualification?
Yeah, so when we launched E7 Health back in 2009, our original name was the Vaccine Center. And part of the reason was that we decided E7 Health's mission was to go into every book of business that adult vaccinations were involved. So we were called the Vaccine Center until 2017. We finally rebranded because people thought that's all we did,
I was
you
about to
know.
say, yeah, you're like, we're gonna have to change the name on that one. We gotta
Right.
make
So because so we went into employee health because employee health required vaccines, like whether you're starting residency or becoming a nurse or a doctor or a respiratory therapist, you have to get vaccines and physicals and drug testing. And then travel medicine, if you're traveling to developing nations, you need travel vaccines and
hmm
student health, if you're starting schools. And so we went into every book of business that adult vaccinations were involved. So we really became the adult vaccination experts. So we were at the exclusion of doing primary care or urgent care. So if you came to our clinic and your tummy hurt, we didn't see you. We referred you out to primary care. So we didn't do primary care. We didn't do urgent care. We didn't see sick people. We just saw preventative health and wellness as involved adult vaccinations. So yes, we became vaccine experts because that's all we did. It
hmm
wasn't like a side thing, like Walgreens sells you vaccines, but they're also selling you diapers and chips and candy and drinks, right?
Yes.
This is not all they do, right? And even urgent cares, and we'll give a vaccine here and there, but they're busy stitching people up and other stuff. So when this is all you do, so the whole concept of vaccine medicine is often treated as a sort of a side thing and
hmm
not too many practices and what have you. We made it our main thing.
I
Uh,
see. I see. Yes.
so we were almost like a COVID company before COVID hit. Everyone pivoted to testing for COVID and whatever. We were testing for chicken pox, measles, mumps, rubella,
Mm.
hepatitis. We were doing titers, which is what a COVID test really is, way before anybody else. So, I joke around that we were a COVID company before COVID hit.
Yeah. So when did the company start?
In
You said
2000,
2009, right?
yeah, 2009, yeah.
Wow. So yeah, you really, because my own internal bias when I saw vaccine expert, I just immediately think COVID vaccine. But you were an expert way before COVID even struck.
Yeah, I mean, well, we're a travel medicine clinic. If you're traveling to South America or Asia or Africa, we saw all these patients, and we were travel medicine experts. So based on CDC guidelines, what vaccines you need: yellow fever vaccine, Japanese
Exactly.
encephalitis, typhoid vaccine. We stocked every adult vaccination available in the United States. We even had access to anthrax vaccine for military contractors. I mean, we were the vaccine experts. And I think for many years, and I think still holds true, we're one of the few clinics in the United States that stocks every available vaccine commercially available, with the exception of COVID, which wasn't available, but to regular clinics. But other than that, we stocked every vaccine available.
Hmm.
Rabies vaccine. I mean, we were the main, I think, company and clinics that focus on adult vaccination prior to COVID.
That's amazing because people, I don't want to generalize or whatever, but I feel like after COVID, people have actually been less or more skeptical of vaccines and just the general efficacy of vaccines and how
No,
helpful they can be. Not they take the COVID one and then they put it over every other one. And like I remember I went to Peru to hike to Machu Picchu or whatever, and we needed the yellow fever, I think typhoid, but those vaccines or like preventative medicine.
yeah,
Um,
you need a acetazolamide for high altitude sickness
yes,
prevention. Hey,
we
yeah,
did. So I didn't take that, but my brother actually he had a bad run-in with altitude sickness up
right.
there.
But
He but
here, but I mean, like, what other clinic could give you like insight into what you do in Machu Picchu unless you're going to a travel medicine clinic? Like, your
exactly.
primary care doctor is not going to sit there and understand, oh, Machu Picchu versus Kenya versus Tanzania versus, I mean, so this is what makes a travel medicine specialty unique, because just like ER medicine, you wouldn't go see your ophthalmologist, if you hurt your knee, right? You go to the
Yeah,
ER, or you go to, so same things. We became like travel medicine experts.
I
So
love it.
we we
Yeah.
we, we could speak to all the things you're talking about, whether, what do you do if you get high altitude, you descend, blah blah blah. I mean,
Mm.
we not only did we give the vaccines and the medications, but we also did the counseling specific to where you were going.
Yeah, and was super beneficial because like I was 20 at the time, so I wouldn't have known to have all this stuff pre-planned. I would have assumed that my family physician or wherever I went to go get the actual vaccines, um, I would have assumed that they just knew. But luckily,
Well,
my
well,
uncle,
well,
he
yeah, but you just finished medical school, so you know now as much as your primary care does about travel medicine.
exactly, yeah. And luckily my
And
uncle had a pre-plan. Like he was like, "Oh, I need this." Like
yeah,
acetazolamide wasn't on the table, but he goes there and he's like, "Oh, hey, by the way, this is going to be high
yeah.
altitude. So can we have this, that?" And they're like, "Oh, okay, that makes sense. Prescribe that." But if there's nobody there to say that, that's the whole
Well,
navigating
but
healthcare thing.
no, but I mean, yeah, but you wouldn't manage your own rheumatoid arthritis, or you need to see a travel medicine expert. You
Yes, yeah,
it's not all you need to know is that you need to see a travel medicine expert, right? You don't actually need to know how to treat high altitude or what to do. Just like you don't know if you tear an ACL what to do. You go and see the specialist and they walk you through it. So it's not
exactly.
like people need to know what to do if they go to Machu Picchu, or Thailand or Bali or whatever. They just need to know that they need to see a travel medicine expert.
Yes, and that is exactly what I agree to because that's what I didn't realize at the time. I thought anybody could handle it, but
Yeah,
then I realized that there's a genuine value to expertise
yeah.
in
No,
the
well, but again, you wouldn't be going to see your primary care doctor if you tore your, ACL, or you
yeah.
had, something wrong with your retina. You wouldn't go see your primary care doctor. Why would you go to see your primary care doctor for travel medicine? I think no, not take nothing away from them, but primary care doctors don't know, retina diseases, and you know they
Hmm.
right. I mean, it's just not their fault. It's just not their specialty. And I think people think that primary care doctors know travel medicine, but they don't, because it's not part of their training.
Yeah.
There's no rotation, there's no mentorship, there's no book that they're forced to read. So if you go to most primary care doctors and you say, I'm going to Machu Picchu, what should I do? Maybe some will tell you, but a lot will tell you, okay, just don't drink the water,
Exactly.
and just, you know, whatever, and just be careful. Like that's not a travel medicine consultation.
Hmm.
That's just like advice. And
Yeah.
so I think our biggest struggle is getting people to understand that if you're traveling to a developing nation, you know, you should see a travel medicine expert anywhere. I mean, in any city, you should seek out travel medicine experts who that's what they practice, because it's not just getting the prescription for acetazolamide, it's not just getting the yellow fever vaccine, it's the counseling that goes with it. You know, how to recognize certain things, traveler's diarrhea, what to do. You know, the whole idea of managing eating food in a developing nation is a conversation. The whole idea of, you know, even safety risk, and you know, what is the nearest hospitals that are reliable. You know, you get all of that in a travel medicine consultation, hopefully.
Hmm.
And there's nothing you can figure out. It's like trying to, you know, diagnose your own arrhythmia and treat it.
Yes. I completely agree. Clip everything that you were just saying because that was amazing. You definitely need one of the just a travel um some travel guidance to begin with, and who better than an expert? And so I guess so y'all were already doing y'all were already the vaccine experts by the time COVID rolls around. So then did everything kind of get repurposed into COVID, or were y'all able to still kind of maintain your the typical business flow?
Yeah, no, we kept up the same business flow. I mean, obviously for a month or two, you know, things were rocky as a lot of businesses closed. But no, we just added COVID to the list of things, the viruses that we were concerned about. It was We already had the software technology, and we launched nationwide COVID saliva testing for employers and for people at home, where you know, we'd send them a package. They would, instead of the swab, they would spit in a tube, and, you
Hmm.
know, and FedEx it back to us. And this was, I think we were one of the very few company, or I think we were one of the earliest companies to roll out nationwide COVID saliva testing, uh,
Okay.
at home and at work. A lot of employers used us to test people before they came back to factories, and or once a week testing, you know, that they had. And so we already had the software and technology geared up
Yeah.
for other things. So we just, like, a lot of people had to pivot to COVID. I think we were fortunate enough that we just could add it to the list.
Exactly. That I mean, because you would be the first person really like to have the whole infrastructure and everything to do that. And those are I remember those like swabs that you could send in or do the at-home testing. I always wanted to be able to do those, but as like a healthcare worker, really like as a medical student at during that time, there's not very many options. Like it's kind of you just do whatever. If we say you have to run 2 miles to the COVID center, let them stick a tube up your nose, and then run back here and be ready for work. You would do that in a heartbeat.
Right.
You'd be like, do I need to run in scrubs or can I switch
Yeah.
to gym shorts? You know,
Right.
they and so that's kind of my experience was more like you wouldn't be allowed to use the at-home testing. Some hospitals didn't necessarily accept that one, so I'd have to go get it in different areas. And so I wonder if that's still like I wonder if and it was just based off the hospital. Um, so hopefully some of them at least allowed the saliva testing and some of that other stuff to go through. But I remember in my experience it was like more difficult because I couldn't use at home testing. It just wasn't labeled as like acceptable, even though
Right.
and I don't know that could just be hospital policy not being as quick to jump because I mean everything was moving so quickly.
Right.
But yeah, it was an interesting time, at least for a medical student, because you're in that like service part where no matter what, you have to do. Um, you're essentially the lowest man on the totem pole. So
Hey, you
the
do what you're told. You don't no, you don't give blowback.
yeah, like I remember we were supposed to get the vaccine, and then they told me no, we had to wait till all the physicians got it for better protection and stuff like that. We understood, so we're waiting 2 weeks. In that 2 weeks, I get COVID, and
Oh, you
then
got COVID?
oh yeah, so I had it. It wasn't bad or whatever. Um, but I get it, and it was during one of these rotations, like the ICU, where I didn't have to go in. So luckily, I didn't have to like report myself as sick or report myself missed time. Um, but then I come back, and then like the week after that, they were like, "Okay, well, you're approved now. You need the COVID vaccine." And I was like, "Guys, I think I just had it. Like I'm not
Uh-huh.
sure." And I just at the time, you're kind of like, this probably isn't the smartest medical decision, but I'm doing it for the career or whatever. You have to just make those. And so I get the vaccine. Plus we were in New York and stuff, so like that was when the vaccine passport was rolling out, and so you couldn't do anything if you didn't. So um but yeah, it was just like you just didn't have any options really, which is interesting when you think about like the healthcare workers aspect on that. Because you're just kind of following the rules. And even though you're like, uh, it's not, and I'm
Mhm.
not saying that I was fine after the vaccine. I was fine after COVID. I got COVID again. So
Oh,
evidently it wasn't,
oh,
uh,
oh
or I
no.
didn't, I didn't get confirmed. My, fiance who lives with me, she had it for the second time after the vaccine. So I don't know. It's just, blah, blah, blah. But it was just an interesting or a weird story of you going, I hope this works, or I hope this is fine. And yeah, it's just a funny thing about being like, I guess, a medical student at that time, because you don't have any
No.
power to say, yeah, you would do it if you didn't do all that medical school to stop now. Like you're
Yeah. Well, I
gonna,
think
yeah,
that was always the case. As medical students, you just try to go with the flow.
yeah. You're like, I'll be a test dummy. I'm not even gonna.
Yeah,
I'm
yeah,
already
yeah.
the test dummy.
Yeah, not
Should have shot
nothing's
me
changed.
first.
Yeah, nothing's changed.
Yeah, no, 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 no. Um, and so I don't want to take up too much of your time. I've really enjoyed the conversation, and I do have one more question for you. Do you
Hmm.
remember any? Do you have any stories back to the time when you're either a medical student trying to figure something out, or in your residency where things might have gotten a little chaotic, or like just an interesting experience for some of the people that, because you would have been going through it, I guess, 30 years ago, right? 20 years ago, you said.
Yeah, 20 years ago, yeah. 20,
So
yeah, plus. Uh-huh.
how was your, since I'm starting residency, we'll do that. Like
Yeah.
what what was an experience that you really loved?
Hmm.
Was there one that really made you say, "Hey, I'm glad I'm doing this,"
Yeah,
or was there one that made you say, "Geez"?
yeah. I think maybe I'll just answer it this way. I think when I first started, I found the amount of information that I had to process was very troubling. It was just too much information. You didn't know, you're getting, vital signs and labs. And I remember like my first few months of just so much information, and you want to take it all seriously. And so I didn't really understand what how to filter all that, because everything seemed important to me.
Mhm.
Right. And what was interesting is I remember very early on, I had a attending physician who said something very curious one time on rounds. It was just a quick comment he made. And he said, you know what? And I don't think he said it in a boasting way. He was an older physician, white hair. Uh, and he said, I can walk into a room to see a new patient, and within, like, even in the hospital, he goes, within like 10, 20, 30 seconds, I can tell how sick the patient is by just walking into the room. And I thought, this was, I just couldn't believe that. I wasn't having any of that at all. Right. Like, what do you mean? You walk into a room
Hmm.
and you look at the patient and you know how sick, meaning when I say how sick, I think he meant like, hey, do we need to jump on this person? Or, we need to get a stat, CT or a stat this or a stat EKG, or, we just order something and check on them tomorrow. I think it was that sense of just eyeballing the patient, and you had a sense. Even in an ER rotation, you walk into a room and you just eyeball the person. You're like, holy moly, come on, let me get some help into this guy's. And so what was interesting is I thought maybe a little bit, but I didn't really accept it at all. I thought it was just, I don't know what he's talking about. You need to do good physical, you need to listen to the heart, you need to get some labs, and then you can figure out how sick the person really is. And of course, I don't know how long it took, 10, 15, 5, 10, 15 years. But then I realized, oh yeah, I'm doing that. I mean, I'm walking into, I still, do the physical and do all that stuff, but immediately, you just walk in and just this aura that patients have that they need a lot of my attention right now. And I got to drop everything I'm doing, or let me just order some routine labs and check on them later or something. And I didn't buy that. I didn't accept it. But you wind up eventually becoming that person,
Hmm.
after enough experience under your belt. I don't know if that means anything to you, if that helps you, but
No,
that's a very interesting phenomenon.
I love it. I'm glad that we're ending on that because my mom, as her being an emergency physician, she mentioned the same phenomenon. Like she could just kind of tell. And there was a couple times I used to scribe even before medical school. I look back of where I would be bouncing around with all these ER physicians, and I would see somebody think they're really sick, and then they would just be like, "Ah, it's fine," and then it would be fine, and then I
Yeah.
would see someone, and then you start to kind of pick up, like once I am in medical school and everything, I see somebody in a very similar situation as the person that was sick that I kind of was like, I'm a little skeptical, and I'm like, okay, no, I think this is something going on right here.
Yeah.
The joke is that you can always tell when someone's got a kidney stone because they're standing up, pacing around the room.
Yeah.
When you enter the room,
Right.
most people are sitting, and
Yeah.
so it's amazing. But that's kind of medicine, though, is that it is a learned science, almost like or a practical science. So you almost learn how to treat people just as much as knowing the numbers,
You're right.
and people
Well,
are weird.
let's just call it a part of it is science, part of it is art. And when people say the art of medicine, that is the art. The art
Hmm.
is I've got so much, miles under my belt that I can use some of that in addition to the science part, in addition to doing a great physical, ordering the labs, and listening to the patient and getting a great history. In addition to that, you pick up on subtle cues that only come from experience.
I love that. The art of medicine. Now I can now I just got to get good at it.
You're right.
But
Well, it just requires experience.
um well, thank you so much, Dr. Bakhtari, for joining us. We've
Yeah.
really enjoyed it. I've really enjoyed the conversation. And so you can find him at Baktari MD. It's a podcast, correct?
BaktariMD.com is a website, but it has our podcast, or you can go to YouTube, Baktari MD, or Spotify, or on all the regular apps. But all our content is on BaktariMD.com, including featured podcasts, blogs, as well as information about what we're doing. So yeah, everything's on BaktariMD.com, but YouTube, Spotify, and also people can also go on LinkedIn to Baktari MD, and they can also, if they have any thoughts or questions, they can reach me that way.
Yeah. Find him there. The website's actually very easily accessible and
No, thank you.
pretty neat. But yeah, and you also have enational testing, and
Right.
E7 and all that. So you can anybody that is interested in those topics, please look into that as well. They're at the front. They're really trying to help out medicine in general right now. So,
Yeah. Yeah.
we really appreciate it. And if anybody else wants to, if you have any questions, you can reach us at Off White Coat Podcast. gmail.com, or find us on any of the social medias. And we really just want to say thank you, Dr. Baktari.
Oh,
It's great.
yeah, it's my pleasure, and good luck on your journey. So I'm excited for you.
Thank you so much. All right,
All right,
everybody.
people.
Thank
Thank
you.
you.